Second answer choice was something called cryoglobulinemia. And actually, this condition, which is rather generic, you can divide this beautifully into the two terms. Cryo in Greek means frigid and freezing. Globulin means protein. Where am I? Where am I? Well, I'm at home. Where are you? No. Where are you in your body would be really the question. You're in your vascular compartment. You're in your blood. You divide your blood into plasma and serum, don't you? Yes, you do. What's the difference between the two, and what does that have to do with cryoglobulinemia? What does a globulin mean? Protein, doesn't it? Where all do you have protein in your vascular compartment? Perhaps you have it in your plasma? Of course you do. You also have it in your serum? Of course you do. Yes, you do. You have globulin in both compartments. I'm dividing into plasma and serum. So, before we get there, let's lay down some foundation. Cryo, less than 37 degrees Celsius. Why? Because body temperature is 37 degrees Celsius. So, something has occurred in which the environment has become cold. When such a cold environment has taken place, understand that now you will then take these proteins, and we haven't identified exactly as to what they are as of yet, but we've divided into plasma and serum thus far, and they precipitate. So these are called cryoprecipitate. This you've heard of. If you haven't, know it. Now, let's go ahead and divide that further. So precipitate of what proteins? Well, maybe globulin. When you say globulin, what are you thinking about? Proteins, such as immunoglobulins? Maybe clotting factors? Yes. So therefore, globulin would be a component found in both plasma or serum. Is that clear? So what's the difference between the two? Now, well, I'll tell you. I'm not going to just tell you. I'm going to give you an example. Think of a patient that just experienced a wound, okay? And this wound undergoes a clotting process. There's hemostasis taking place, and then eventually what are you going to do? You're going to form a clot, aren't you? You're going to form a clot. When you form a clot, what then happens? You form a scab, do you not? Yes. You form a scab. You used up your clotting factors. What were they? Oh, well, maybe you had platelets coming in, and you introduced a wound. So what did you do? You took that platelet and then you bound it. Bound it to where? You bound it to your von Willebrand factor, a subendothelial collagen, have you not? Von Willebrand factor binds to glycoprotein 1b, and then you have, at this point, adhesion. Then you have glycoprotein 2b3a, and what is that going to do? Well, you take the platelet. What's a platelet? A platelet's like asphalt, isn't it? If you have a pothole, you fill up that pothole with asphalt. That's what these platelets are. So far, we've laid down platelets. Now you're going to start bringing in more platelets, and you're going to aggregate them together, and that is through your 2b3a. And between those 2b3a is what, please? Fibrinogen. Right? And these are clotting factors, aren't they? Because you're forming a scab. And eventually what happens? Well, at some point, maybe you used up your clotting factors in that environment, and there's a little bit of fluid that is escaping from that scab. Tell me about that fluid escaping from that scab. Clotting factor free or clotting factor filled? It is clotting factor free. It's free of clotting factors. What do you call that fluid that's oozing out of your scab? Isn't that pretty? Maybe you're having a sip of coffee. Think about that serum coming out of that scab. That's always pretty. So what's happening, please? It's clotting factor free. That's what serum is. What's plasma? Plasma is all proteins, including clotting factors. Is that clear? Are you picturing this? You should be. Close your eyes. There you are. Okay. So now that you have your serum, and now that you have your plasma, they both are proteins, don't they? But the serum, remember, it's a clotting factor, fibrinogen and such. Is that the only protein that you have in your blood? No, not at all. You have immunoglobulins and such, do you not? You have other proteins such as albumin, so on and so forth. Understand the serum is going to be completely clotting factor free. That's it, but other proteins could be present. So when you say cryoglobulin, please understand that it represents both the serum and the plasma. The other type of cryoprecipitate is called fibrinogen. Now, what's the clinical relevance of this? Well, the clinical relevance of cryoprecipitate is that there are instances in which you would want to give this therapeutically. Is that clear? What are those instances? Well, let's take a look. Let's say that you have a patient that comes in and is bleeding heavily, bleeding heavily to the point where there's bleeding into your joints and such. It's called hemarthrosis. Through further labs, you end up finding an increase in PTT. Okay, let's walk backwards, shall we? An increase in PTT. You know that PTT is measuring what branch of the coagulation cascade. You do know that it's the intrinsic branch, don't you? I know you do. Because that branch begins with factor 12, 11, 9, 8. So far, all I've told you is PTT has been elevated. What about PT? Normal, INR. Next, bleeding time, normal. So far, the only thing that we have is hemarthrosis, pretty heavy bleeding, and an increase in PTT. Then, at some point, you come to also find out that there is factor 8 deficiency. You've come to conclude that. So, you call this what, please? Diagnosis thus far? Hemophilia. Which one? Good. Hemophilia A. Hemophilia B, 9. What's the next number after 8? I think it's 9. I think you're right. So that'd be hemophilia B, also known as Christmas disease, isn't it? Let's focus on 8, please. I'll give you another patient. A female comes in, severe menorrhagia. Hey, doc, I am bleeding so much that when I come out of the bathroom, I feel as though, it looks as though that I'm walking out of a murder scene. Or wake up in the morning and I have my tampons in. I even have pads on, and yet my sheets are soaking with blood. So you do what's known as a rice-Acetin assay, and you find that von Willebrand factor is deficient. And upon further hemodynamic tests, you find an increase in bleeding time above 7 minutes, and you also find an increase in PTT. What about your bleeding time in hemophilia A? Perfectly normal. What about PTT? It was elevated. In von Willebrand factor or von Willebrand disease, this one specifically, there are different types. When von Willebrand factor is deficient, please understand that you do not have proper adhesion of your platelets, thus resulting in increasing bleeding time. And you also have an increase in PTT because von Willebrand factor is supportive to which factor in the intrinsic coagulation cascade? And you have all correctly told me that it is factor 8, isn't it? So for all intent and purposes, if a patient is deficient of von Willebrand factor, that patient is deficient of factor 8 or suboptimal functioning of your factor 8, therefore resulting in an increase in PTT. Very rarely do you have any diseases that give you such a clinical picture. Why am I bringing these up? Because I told you Precipitate could be a possible therapeutic means to certain conditions. Here they are. Precipitate means what? 2 types, cryoglobulins and cryofibrinogen. You put them together because here, with Precipitate, maybe your patient, you need to replenish with von Willebrand factor. Maybe you need to replenish this patient with factor 8. Maybe you need to replenish that fibrinogen. Precipitate. Pretty straightforward. Let me give you another patient. So this is a patient. So we talked about Precipitate a little bit. Fantastic. Let's talk about a little bit more. What are we doing now? We give you another patient, 74-year-old. So far, same age. Male, so far, same patient. No different. Next, you end up finding increase or elevated levels of calcium, hypercalcemia. They give you serum protein electrophoresis, SPE, serum protein electrophoresis. Upon electrophoresis with protein, you would find that the largest hump and the most abundant protein in circulation is albumin. And you have alpha 1 and beta 1. I'm not too worried about those, but then I want you to pay attention to the gamma. The gamma wave here is no longer a wave, it's an actual spike. That spike is then representing what? Immunoglobulins. With this type of history that I give any patient with lytic bone lesions, hypercalcemia, so on and so forth, and I find an increase in immunoglobulin G, in IgA, I understand your patient most likely has multiple myeloma. What is immunoglobulin? A protein. So under environments that are cold, it is possible that those immunoglobulins may then become precipitated. Yes. Is that cryoglobulinemia? Yes, it is. Are there different types of cryoglobulinemia? Yes, there are. You can have monoclonal type of gammopathies, such as monoclonal gammopathy of undetermined significance, multiple myeloma, Waldenstrom macroglobulinemia, tongue twister. What about chronic hepatitis C and such? Yeah, that's a different type of, you could have excess protein, and that would be more of an immunologic type of reaction in which those immunoglobulins that are being produced in chronic conditions, hepatitis C, in which there has been quite a bit of research, and there's a lot more detail. So we know a lot about what may then happen and why there is cryoglobulinemia with chronic hepatitis C. But that would be more or less your polyclonal type of gammopathy, huh? So cryoglobulinemia. So far we have two options or two answer choices, differentials for a patient. 74-year-old male with atrial fibrillation, and you're worried about thrombi formation and warfarin. Are you worried about protein being developed in the left atrium due to atrial fibrillation? Are you kidding me? Thrombi formation, yes, but not protein. So cryoglobulinemia would be highly unlikely. Achenbach syndrome, this is not a sudden type of onset. And was it the atrial fibrillation and thrombi and then resulting in the coloration or the blue discoloration of the toes? That's really the true question that you want to ask yourself. Or was it the medication the patient was taking? We'll take a pause here, allow you to digest the material that we've talked about. It's all about taking all this information and dividing it into chunks and making sure that you at least know the fundamentals before you go on to any type of clinical application. I'll see you in a little bit.